Good morning, everybody, and welcome to the Friday Clinical Informatics PowerTalk series. I'm very happy to introduce today's speaker, Dr. Raymonde. He's a physician informaticist with many years of experience with the he works with the National Association of Community Health Centers. He is essential for supporting any clinical informatics needs for all the research and grants going on there for many different kinds of conditions. He also has been responsible for the creation and curation of more than 100 VSAC published value sets, grouping terminology standards such as ICD, SNOMED, LOINC, RxNorm, that are used for big data extraction and analytics for CDC reporting and other agencies. All these efforts support interoperability and quality improvement between vendors, quality measures, meaningful use, et cetera. He completed his postdoc research fellowship in biomedical informatics at the NLM. So I'm happy to introduce him. His title of his talk, Public and Population Health Informatics Challenges in Addressing Health Disparities.
Thank you, Dr. Wang, and good morning, everyone. And let's just dive right into it. So just for everyone who doesn't know what NAC is, or the National Association of Community Health Centers, we were founded 50 years ago, more than 50 years ago, to really help our community health centers and federally qualified health centers who are catering to our underserved populations, both in urban and rural environments, and just really helping them both from the policy side of things, direct community support, provider resources, training and technical assistance. And now in the past 2 years, the clinical informatics team has been established within the clinical affairs division. And we are truly trying to spearhead the organization to really more informatics driven approaches to addressing the community health center problems, specifically health inequity, health disparities, and all of the good stuff all the good and bad stuff that you're seeing right now. Before I begin, I want to kind of show this really nice diagram of what really demarcates public health informatics and population health informatics. There is, as you know, the AMIA definition of bioinformatics, and from top to bottom, population to the individual level, right, and bench to bedside type of categorization. But here on the left, you'll see public health informatics really focusing on the larger group, right? Like essential services, which includes non-clinical services. Example of this would be using ODH, or the Occupational Data for Health framework from CDC's NIOSH, to help to try to collect industry and occupation data to help identify essential workers, for example. So that is a public health initiative, or public health informatics type of project or initiative. And on the right-hand side, you'll see population health informatics. So within specific populations in a big cohort or big group. So you can imagine the US population, the whole US, the population, specific subpopulations of that, for example, the underserved population, homeless population, those who are food insecure, those who are experiencing substance abuse, for example. So you can kind of have different sets of populations and what are the care needs of those populations and what you can do to address those using informatics. Global informatics, we're not really going to be focusing on that because we want to focus domestically here. But of course, from your experiences, maybe you guys come from different low resource settings, such as I came from the Philippines, and that's a very low resource quote unquote developing country. There are different challenges there too. And on the middle of this all would be data science, and how we use data science, and what kind of tools and techniques we use from a clinical informatics perspective to assist with data science, not necessarily doing the analytics itself, but creating the infrastructure and frameworks to be able to do data science properly. So we want to focus a lot on social determinants of health. Some might hear social drivers of health instead. Some might hear social behavioral determinants of health, SDOH or SBDH. And I highlighted one or two things here, which is social determinants of health data that are not captured in a consistent structural way using standard terminologies, which you guys are very much aware of already, will not be easily transmitted or aggregated. And I have more slides, so I'm going to go through this really quickly. This figure is this is a crosswalk between what's in the Institute of Medicine Social Determinants of Health questionnaire and what is being captured using a questionnaire called PREPARE, P-R-A-P-A-R-E, which is a social determinants of health capture or survey tool um, being created and maintained by our organization, NAC. You'll see these have 4 domains. From the left would be social demographic. You see age, gender, race, ethnicity, education, employment. Those that are highlighted in gray, both questionnaires are trying to capture that, with the green ones specific to PREPARE and the blue ones specific to IOM. And you'll see that there are overlaps and there are things that are specific only to other questionnaires. There are other questionnaires that are out now, such as the SDOH wheel. I believe that's from EPIC. There are other institutions and electronic health record vendors who are focusing on their own tools, standardized or non-standardized ways or proprietary ways of capturing social determinants of health data. You'll see in the middle here, psychological and behavioral data elements. And on the right-hand side would be more individual level and social relationship levels of SDOH, such as violence, domestic violence, social support, work conditions, history of incarceration leading to less access to health, for example, military service, and what's missing here would be, for example, transportation insecurity. If you can't go to the clinic, you won't be able to access healthcare. We're trying to modernize this, of course. More examples of this would be internet access as a social determinant or driver of health. If you don't have internet and you don't have transportation, you won't be able to do any telehealth a way to interact with your providers, maybe via phone. And some folks don't even have phones. So there's something called material insecurity that kind of captures that. So PREPARE, what is PREPARE? It is a national standard, standardized patient risk assessment. It is a protocol built in or trying to be built into EHRs to engage patients in capturing, again, SDOH data. It can be customized and it can respond. It really wants to respond to the needs of the patients and not necessarily just capturing data. These are the different domains here. You'll see something here called UDS. So what's UDS? For those who are not in the community health center experience in CHCs or FQHCs, the UDS is the Uniform Data System. So each year, health center grantees and health center lookalikes report their data, performance data using different measures defined in the system. And it's a standardized reporting system that provides consistent information about health centers. And what you're seeing in here on your screen, you have the core domains. You see UDS, SDOH domains such as race, ethnicity, veteran status, farm worker status, language proficiency, specifically English, income levels. So specifically, we have a big population of those who are way below the federal poverty level or FPL percent. Insurance, neighborhood security or neighborhood environment, housing status and housing stability. So if you're homeless or if you're home insecure, those are being captured in that questionnaire. There are also non-UDS, which means these health centers are not required to report these domains through the uniform data system, but they are all still being captured, such as educational levels, employment status, material security, social isolation, which we're seeing a huge spike in the past 2 years due to the pandemic, stress levels, and again, transportation. There are optional stuff that are being captured, like incarceration, domestic violence, safety, and refugee status. And they're optional because they're very tricky to ask. And most people who have identifying information, who have provided their first names and their last names, we've seen people who want to be anonymous and are not comfortable with sharing these optional information within these domains. And these data, SDOH data, are being captured really to inform state and national policies, again, starting from the individual capture of that data going through health centers and aggregating that from a health center or organizational level onto a higher network. For example, community health centers are usually members of health center controlled networks or primary care associations. That data, the health center data, will roll up to the networks. We might get some payer level data also, and this would help inform local, state, and national policies for what can and cannot be done to address social determinants of health inequity and health inequity. So the focus again is really actionable items or what you can do with these social interventions than actual just coding it, right? And I guess this is kind of just showing you kind of this closed loop, how we envision social determinants of health and looping it to the referral services and for these CBOs or community-based organizations to address that social determinants of health need. If you're housing insecure, is there a CBO addressing housing? And then how do you close that data loop? How do you get that data back onto the health center where you capture that data to kind of update that or to get that data again back and to create value again to inform national and public policy. So why collect standard data? Again, this is kind of obvious for you guys, but we just want to enumerate it. Again, there's better patient care coordination. There's a nice diagram I'll show you guys later. Holding providers accountable for health equity. As you know, we are still shifting from a volume-based care to a value-based care model and institutional-based care model to a home-based care model or individual care model, as you have been seeing this past like 5 years or 10 years. To help build again capacity for these health systems to achieve better outcomes through, for them not attesting to having better care, but to actually show data that they are giving better care through different electronic clinical quality measures. Understanding how social interventions impact delivery and care outcomes, sustainable funding and reimbursements for different social interventions, and to manage really limited resources. You'll see that most health centers don't have informaticists. They would have business analysts doing their clinical data. And most of the time, their data analysts, and not even at the network level, they do not have clinical informaticists or data analysts with a healthcare background to really look at the data, have an understanding of the data, and extract the data in a very meaningful way so that they can be aggregated in a proper way. And what we're seeing in the field this past 2 years is that it's very difficult, even from a health information exchange standpoint and data extraction standpoint. You will receive data that don't have standardized codes with them. They would have different free text descriptions. They won't be semantically equal. There's a lot of different challenges that we are facing. And those are kind of, I'm just kind of setting the stage here because it's you will see later on these challenges are big barriers for informing policy in that level. There is little data available, not because they're not being collected properly, but also they're not being queried properly, and they're not being funded to get that data properly also. There are coding guidelines such as ICD-10 Z codes, which started in 2016. Coding for Z codes, which represent the encounter reason for the visit, and it also ICD-10 Z codes capture social determinants of health data. Those are not reimbursable codes. So if you code it, the providers for your physicians, your nurses, or your medical your MAs, they won't have this motivation to use these Z codes because there's no monetary incentive, right? They're not reimbursed. There's lack of funding for payers to collect Z codes, but again, this is kind of changing because of a client needs, or just really that's kind of a this whole the whole COVID-19 epidemic has really set the stage for pushing this type of a community health or population health agenda. And again, sustainability. You guys have heard about the Forever pilot projects and research projects. There we have more pilots than real interventions happening in the field. And these pilots, although good on paper, though don't get translated onto the field due to lack of a business model or lack of general funding, or you graduated and moved on to a different work. So there's a lot of that problem. There are also different other problems with, especially with verifying unique individuals. As you know, we still don't have really a global a US-based unique identifier. You can't use social security numbers, of course, because those get reused. There is a good list of rules for having really unique IDs. We see that in Korea, we see it in other countries, and it's working out. It's just that we here in the US do not have a really good way of having a unique ID per person, for individual person. Then you encounter proprietary technical infrastructure where different EHR ecosystems or other ecosystems who say that, yes, we are supporting all of these open standards and terminologies, but when you start querying and asking them for these codes and for their data through different projects and different fundings, public health fundings, you would encounter proprietary codes such as EPIC codes, Cerner codes. What else? You have LabCorp codes for labs. There's a Quest Diagnostics proprietary code, and it's very difficult to find crosswalks between, for example, LOIN codes and those LabCorp and Quest Diagnostic codes, which makes it even more difficult to get lab information from community health centers and specific populations. Last but not least, the lack of technical infrastructure. Again, there's not enough informaticists out there and engineers who are working together to create these kinds of connections and technical infrastructures to connect these disparate systems together. So that's why we need you guys, and we need everyone to start collaborating and talking to each other. Thankfully, there are initiatives that are trying to address all of these key issues, and there are a plethora of organizations. So what you're seeing is a nice diagram for the National Alliance to Impact the Social Determinants of Health, or NASDO, NASDOH. You see Opportunity 1, Consumer-Directed Permissions of SDOH Information Sharing. SDOH information should only be transmitted if you get the consent of the patient, which might be outside of the clinical consent of clinical data. So that's a data governance question and informed consent question. Opportunity about ease of collection, easing the collection of the SDOH data for again addressing social needs. For efforts to verify identity or to help de-identify and re-identify patients when doing data projects. So there's a tool called PPRL, the privacy preserving record linkage, where something is de-identified. There's a way to relink it back into their EHR system. So there are initiatives from MITRE Corporation in helping the opportunity number 3. Number 4, facilitating interoperability. There are efforts with that, and one of them is called the Gravity Project, where the Gravity Project is a consortium which helps identify common data elements and associated value sets for social determinants of health. So we're trying to they are a group that tries to harmonize and tries to make sure that the SDOH elements are kind of semantically sound and what's applicable in the field, and we don't get any wastebasket codes that really don't mean or are not actionable. And number 5, facilitating access to eligibility and enrollment to different social or human service programs that address those social needs. And all of these SDOH questionnaires can be rolled up into a FHIR questionnaire app. And there's a free tool by the National Library of Medicine to turn any kind of clinical questionnaire or survey questionnaire into a FHIR questionnaire, a FHIR app. So you can kind of do those things, or you can create initiatives to create these FHIR apps to make things interoperable. And really understanding the role of open standards and standard terminologies for exchanging SDOH information. Clinical information, sure, there's a lot of work on that, but for social determinants of health, that is really, really tricky. You've seen this, another model of how to drive EHR vendors to support social determinants or drivers of health product development. That's really a big push from the clients and us being the community health centers being the actual clients who are asking for vendor support, EHR vendor support, on how to capture social determinants of health data with a terminology backend, and for them to represent SDOH captured data using standards and not going into their database as a description or free text. So there are more efforts to inform vendors and to inform the clients that they are in fact ways for them to ask the AHR vendors in the proper way to support these using open standards and terminologies. But again, more work needs to be done in helping health centers understand these and have more kind of push the vendors to help support them again. And again, this again rolls up again to policy. And there's again, you'll see a really systemic variability in and lack of standardization in the usability of SDOH data in its current form or right now and what we're seeing. I guess you'll see here different stakeholders and the different ways where the data kind of gets transmitted from. You can start from, I guess, in the middle, the EHRs. The EHRs are supposedly submitting this to third-party population health companies such as Azara, for example. That's one of the big third-party population health analytics vendors. Other referrals or CBOs, again, community-based organizations or care coordination organizations who are helping address these social determinants of health needs. And where are these social determinants of health information logged into the system? So you would think that it goes to the problem list, right? So here's an interesting screenshot of just a problem list. The big problem with problem lists would be the lack of time that providers have in updating the problem lists. A good example of this would be you will see a problem list representing pregnancy in a person who was pregnant. Once the pregnant woman has delivered in the hospital and comes back for their follow-up checkup, they are still pregnant, and the problem list, the pregnancy code has not been removed. So the patient has been pregnant for years and years because it hasn't been removed in their problem list. And it can be the same for social determinants of health. Does it go to the problem list? Should it be captured in the social history of the patient? Should it be captured in the demographics part? When should it be captured? Should patients be inputting their social determinants of health information by themselves in the waiting room? So there's all of these points of capture and all of these complex workflows that we're seeing, which adds to the challenge of capturing this data to make that data actionable and traceable. For those who are not aware, there's something called US Core or USCDI, the US Core data for interoperability. We are now currently on draft version 3, dated January 2022. This was originally called the Meaningful Use Common Clinical Dataset, and this is these are required data classes and data elements for EHR vendors to be supporting these data elements using standard terminologies so that we can kind of interoperate at the most basic level. Again, the USCDI established a minimum set of data classes that are required for nationwide interoperability. What you're seeing here would be version 1 of USCDI. You're seeing it on the left. And you will notice that on version 1, there is no data class specific for social determinants of health. But on the right-hand side, you will see last year's draft version 2, and you will see that unfortunately, a lot of social determinants of health data elements were in comment status. Comment status is the USCDI group has said that these data elements do not have a big support right now, or they're not represented properly in vendors and systems, and so that's why they do not roll up into the actual draft version. This is the USCDI version 3 draft, and thankfully you'll see it highlighted here in the red bounding boxes. Social determinants of health assessment, problems, health concerns, and interventions are now data elements under different data classes in USCDI version 3. So we are thankful for this support, but more work needs to be done in supporting this and really establishing a single source of truth for which codes and how different SDOH things need to be represented. And again, all of these elements come from the ONC's ISA or ISA, the Interoperability Standards Advisory. They do an environmental scan of different content, standard-based content that should be promoted to USCDI. So asking you guys when you are already out in the field to support USCDI and the promotion of community-based or social determinants of health classes. So you'll see it here. These are ISA or ISA elements, vocabularies, and terminologies. And on the right-hand side, you'll see alcohol use, depression, drug use or drug abuse, violence, and all of these things that we see in all of these social determinants of health questionnaires. This is a nice information for you guys if you wanted to kind of support this again. You can log in and support the promotion of different data classes. If you don't really care so much about social determinant stuff, but you care about other things such as pregnancy status, which is not a formal data element that's being captured in a way. So again, if you're pregnant, there should be something in the EMR that says you're pregnant, and we're seeing that that's not the case here. Comment level again is novel usage. Level 1 is for pilot. Level 2, it has evidence of great impact. And level 3, which is nationwide adoption. I'm going to pause here and show you this information. We all talk in different languages. We all talk in different ways. I don't have to tell you that kind of standards are kind of in a similar way, or we are representing concepts in a machine understandable and semantically machine relatable way. And that's just kind of my nice analogy for folks who are not really in the clinical informatics field. And again, Gravity project addresses this creation of SDOH common data elements. Similar to what you're seeing on the right-hand side here, there's something called M-code. These are minimal clinical oncology data elements. So these are condition-specific common data elements. Just imagine your patient who is suffering from different social determinants of health needs, and you can create kind of this cognitive map or a map similar to SNOMED. So what you've seen in SNOMED, so what causes, for example, homelessness, and what are the elements that lead to continued homelessness and continued food insecurity. The build out, we really need more support for people who would help represent these things or build these things. Everyone is aware of this. We're still in this interoperability nightmare. But through common data elements, it's kind of the future vision. I guess we want this to be seamless. We want things to be semantically interoperable. And this applies to different stakeholders all rolling up and agreeing to these common data elements. Here is a nice tabulation of the Z codes, ICD-10 Z codes that represent social determinants of health. It's starting from Z55 and sequentially down to Z65. You can kind of just read this by yourselves, but again, each Z code category here represents different SDOH categories. These are optional, and we're not. And I'll show you in the next slide here what is using Z codes are for. Lots of physicians I've talked to are kind of embarrassed that they really don't have time to encode using these C codes, and it's understandable seeing the lack or the difficulties in maintaining providers to continue working in community health centers. Again, they are in rural places. Although the salaries and the reimbursements for working in community health centers or underserved communities are higher than urban practices, the amount or volume of patients can be said to be unfortunately undesirable, especially for those who want to really work more in urban environments and don't necessarily need to drive an hour away to get into an urban city. So Z codes, again, step 1, step 5, collection of data, documentation of data, mapping of these data into Z codes. So again, there are some systems that capture SDOH data, but not in a standardized way. There are ways to map these to different Z codes or to all of these different standards. Using these Z codes, Z code data, and creating meaning out of them and creating impactful action items out of the data is important. And again, reporting this SDOH data to leadership to show them what is happening, and you can this SDOH Z code data can roll up to your healthcare administrators, can help inform the healthcare team where the deficiencies are, and we also need the support of coding professionals who, for those who are not busy and using a third party, so those physician practices who outsource their coding to third party coding companies. There is a mapping documentation for different SDOH elements and how they roll up to LOINC codes, SNOMED codes, and different ICD-10 Z codes, and internal prepare codes. So that is available. You can go to the website and check it out for yourself. And you can kind of support this also if you would like. This is what the prepare questionnaire looks like. So PREPARE stands for, again, Protocol for Responding to and Assessing Patients' Assets, Risk, and Experiences. You'll see the first parts of the question, you'll see it on the top, would be mostly demographic information, questions about race. We do know that different race and ethnicities have different experiences in the healthcare system. We are seeing a lot of inequities and healthcare disparities among African-American populations, Asian populations, and Hispanic populations. And again, having this data and seeing what resources and what social determinants and drivers of health information and disparities we're seeing between different populations and the analytics that go into there will really help inform funding, will help inform policies. And I keep on repeating myself because this is a really important aspect of it. We're seeing it's two routes of these things. Either the client, there's an outreach, an outcry from the clients to create policy or law that informs them, that mandates them to do it, or there is a business case or a financial incentive for them to capture this information through grants maybe, or through other business models. I showed ICD-10 and ICD-11 here because, again, ICD-10 uses these Z codes. This will eventually, maybe in the next 10, 20 years, when we adopt ICD-11, we'll roll to chapter 24 of ICD-11. ICD-11 came into effect last January 2022, and it kind of has similarities to SNOMED, where it now has a semantic network similar to SNOMED. It has a poly hierarchy, right? And have different terms can have multiple parents. So we were hoping that we would have better representation of social determinants of health as terminologies kind of adopt to these. So again, all of this discussion rolls up to what's called a care plan. So what is a care plan? This is not really a new concept. During the 80s, there's a manual care plan. It was pretty static structure where there's a problem, there's an intervention, there are variances of those interventions and problems, and care coordination was done pretty manually. And you still see this today. But the cornerstone of our vision of the future would be to represent different parts of the care plan as different FI resources. So the health concerns, the goals, interventions, and outcomes need to be represented properly. And this is more dynamic because, again, if we have things coded and we have standards to support these, then we'll be able to do all of these computable processes. To support what's called the closed loop referral process in community-based work or social work. Let's start with 1 going up to 4 on the diagram on the right. An assessment or survey instrument is used to collect that data, and this is usually coded in LOINC if it's a survey instrument, for example. Health concerns or problems are defined using ICD-10 Z codes or through SNOMED CT concepts. Then patient goals are established through LOINC observations. And then interventions would be represented through either SNOMED or CPT codes or HCPCS codes, community-based organizations will execute those interventions, document those procedures that have been done, And hopefully that data, that procedures that CBOs have done will inform or will align properly with quality measures. Um, and the development of electronic quality measures nowadays are informed by the data um, received from our health centers, um, especially those quality measures that are directed to help support under the underserved populations. This is a nice diagram showing how EHR data is being captured with the consent of the patient. The practitioner or provider captures this, and through a FAR API, the data can be exchanged through, of course, express consent by the patient to a coordination platform, a community-based organization, or again, other coordination platforms. And again, the exchange of that data is variable. So this is kind of the proposed SDOH exchange workflow. So why, again, are shared care plans important? And I apologize for this really wordy slide, but we really want a consensus-driven care plan based on clinical practice guidelines, where care team members can prioritize patient-directed goals or patient goals that are created through a patient and provider dialogue. And this is really what you're seeing right now. If you're reading it, it's really mostly a human-centered design approach to creating care plans. It's a migration of, again, human-centered design and evidence-based medicine all in one, and creating, again, that closed-loop referral system, enabling what you're seeing in the bottom here, a longitudinal coordination of care. This is being done because we know that the high-risk populations are the top 1% spenders of all healthcare spending, and through this survey, we are seeing, again, more efforts shifting less of institutional services to home and community-based services, and we seeing the effects of this nowadays, where there's less. We are addressing chronic diseases through community-based or home-based approaches, such as self-monitored blood pressure at home, and telehealth services, for example, and more telemedicine intervention. I wanted to put VSAC here, or the Value Set Authority Center, because it has a FHIR terminology service, it has a RESTful API. Once all of these social determinants of health are represented on VSAC or different systems with a value set OID, then those can be referred to, and you can get value sets that represent different social terms, such as I'll show you guys examples of that. This is our different social determinants of health profiles and elements and HL7 and FHIR. And I'll show you some value sets here. This is a value set for social determinants of health goals, stewarded by the Gravity Project. You will see food security, employment, housing, and all of these things as goals of the patient. And most of these are interestingly represented in SNOMED CT. And maybe you should ask, we've asked all of our community health center partners if they support SNOMED CT and asked for SNOMED CT codes, and it has been very spotty. So it kind of makes this these processes and interventions in the field even more problematic, because a lot of social determinants of health, the granular data about SDOH is in SNOMED and not represented in ICD-10Z codes. You'll see it here. There's Z59 code. You'll see it in the bottom row 2, homelessness unspecified, and ICD-10-CM. And then you'll see SNOMED CT homelessness has more granularity. It shows imminent risk of homelessness, frequent changes in places of residence, right? Transients in residence, and all of that stuff. So the requests also and the procedures addressing those social determinants of health goals, you'll see it here. There are 2 CPT codes, 96161 and 96160, CPT codes for collecting social determinants of health data, and thankfully this is reimbursable. The typical approach nowadays, and you're seeing this now, is that the patient reports a problem. You'll see it in the orange. The provider documents that issue and then the provider prescribes. That's kind of how it's been traditionally done. It's still being done right now. It makes sense. It's simple. That's fine. But what new approach that we want to arrive at is that patients don't come to their doctors just for medical concerns, and any physician will tell you that their patients really trust them with not just with medical concerns, but also with social determinants of health concerns. And sometimes patients will go to their doctor not necessarily for medical concerns, but sometimes you just want to talk to someone, or the provider is their gateway to reaching the social CBOs, or organizations that address social needs. So you'll see here in the top, the medical concern: this patient has diabetes and back pain, coded in SNOMED and ICD. The provider notes that, and it goes to the care plan for diabetic medications and diabetes management. You'll see in the middle would be homelessness. So together with diabetes and diabetes, you'll see homelessness and food insecurity, which gets referred to the social worker or healthcare worker, and they are referred to again to the organizations that may help them with that. And last but not the least, again, mental health is in the spotlight nowadays, especially with loneliness in the past 2 years, which goes to your behavioral health interventionist, and again, which leads to the outcomes you're seeing on the right-hand side column here. Why bother and why do we care? Again, I've already told you, Z codes are not generally reimbursable, but the Z codes will help build the quality measures that will help improve the delivery of value-based care. Seeing the number of Z coding and Z code claims from 2016 to 2019, this was a document published September last year on data that was for data that reaches 2019. You'll see there's an increasing number of Z code claims, which is great. So which means Z code use is increasing. And the top 5 Z code claims in 2019 is homelessness, representing 22% of all Z code claims. And the other high claims incidents would be disappearance and death of family members, problems related to living alone, problems related to living in residential institutions such as boarding schools, for example, those things, and domestic problems or problems in relation with spouses or partners. So that's what we're seeing in the data. And you'll see this is the interesting distribution of Z code claims. You'll see mostly it's on the coasts and the Midwest, California being the biggest coder for Z code claims at 11%. These are the folks who are documenting all the Z code claims. You'll see primary care is really nicely represented here. Family practice, IM, and so for everyone's information, collecting Z codes and coding Z codes into the electronic health record or patient record, you do not need to be a licensed physician or a nurse. Medical assistants and related and folks working in health centers and clinics can in fact code for these Z codes. So yes, you don't need the provider to do that. Why bother and why do we care? We know that 1 in 4 adults with CKD or end-stage renal disease are food insecure, either without hunger, with moderate or severe hunger. And we see this also in diabetic patients. And the reason behind that is because if there's monetary or material insecurity or monetary and financial insecurity, they would tend to get more high-calorie foods that are cheap and easy to get and are easily accessible, or from donations from food sources that might not be nutritional or might not be good for their chronic kidney disease, or might not be good for their metabolic disease or metabolic syndrome or for their diabetes. So raising awareness and again, continuing to collect SDOH data, and in this case related to food insecurities, will help improve targeted interventions and to target and help people with these underserved populations with chronic kidney disease and other chronic diseases. As we know, there's a big burden, big healthcare burden and systemic and financial burden on the US healthcare system with chronic disease. So I welcome you guys to join the Gravity Project. And these are all of the SDOH domains that are being worked on to do, again, to drive different data standards to represent SDOH. It started in 2019. It's multi-stakeholder, and again, everyone is welcome to join. Just type the Gravity Project on Google, and you will check it out. It is a project. It's really a nice public collaboration, and they meet every 4 to 5:30 Eastern Standard Time every Thursday, and I am there every Thursday together with a lot of folks. So just drop in and chime in and really support this project, because this really helps all of the stakeholders really harmonize their approaches and processes and their different problems and solutions to social determinants of health and addressing health inequity. It is a consensus-based approach. You'll see that intervention, screening, diagnosis, and goals are all coded data elements, and these all are represented through different FHIR resources already. It has two streams. There's a terminology domain and the technical FHIR domain. And this is a continuing process, and in the middle of it would be coded and agreed upon value sets. And it is the community that is, again, driving this. So if you are part of that community or subpopulation, please feel free to join us. I know we're at time. I'm almost at the end of my slides. Data flow is complex, especially in the hospitals, it's even more complex, but this image just shows you how complex it is. Where do you capture the social determinants of health data, and where in the workflow, in the data flow, can you make actionable items on this? So really, we just need to keep on doing some Kaizen. We'll just continue to do some lean and agile, and you just continuously improve these processes and closing the loop on all of the SDOH gaps. So I don't know, we have a little time left. I want to open it for discussion or questions. And I see questions here, Jim. There's a question from Dr. Semino here. Has there been any coordination with NIH common data elements? Yes, Jim, there are people who have dropped in from NCI. I haven't seen much representation from the National Library of Medicine in the Gravity meetings and the other SDOH meetings, but I think this is a great opportunity to kind of reach out. If you have, Jim, any folks that you think would be great people that can contribute to this, we will be happy to meet with them and loop them in and really maybe they might have great ideas and kind of push agendas from the NLM and NIH side of things. So that's a great question. Thank you. I did look at Beatrice, Jim, when I was there about 2 years ago to see if there are any social determinants of health information. I was not able to see anything. Again, it's because the clinical center, maybe it's in Crimson, I'm not sure, or maybe it's not being captured in the NIH and in the clinical center in particular. So thanks. Jim, I see you're unmuted.
Yeah, so can you hear me okay?
Yes, sir.
Microphone issues. So thank you for the talk, first of all, and thank you for the answer. For those not familiar, the NIH, the different institutes at the NIH have established common data elements that they use. They require the grantees of the people funded through their research grants, extramural, that is people like us, not at NIH, to use common data elements for recording certain things. And I took a quick look. If you look up cde.nlm.nih.gov, you'll get their homepage and you can look things up. And so I looked up just housing, for instance, and at least a couple of the institutes. I didn't see NCI there, and certainly not NLM, but a couple of the institutes, NINDR, the nursing, and some other they had, they have different ones, but they're all slightly different. There's no standardization. Now, the reason now Beatrice, you mentioned Beatrice. Beatrice is the NIH's sort of I2B2. It's an intramural repository of data from different systems, mainly from the clinical center's electronic medical records, the current one and the previous one, but also from other centers. Strangely, the intramural researchers are not required to use the common data elements. So that's why you don't find them in Beatrice. because nobody's required to use them. But nevertheless, the institutes are requiring their extramural researchers to use them. So if there's coordination between those codes and the codes that, in your project, that would be
Yes, sir.
beneficial, both for the researchers who want to record. I think people want to record this.
Yeah.
And if you give them a list, they'll go, okay, I'll record them this way. That's fine, because saves me having to create it on my own.
Yeah.
But if they don't have it, or they're using one that's not coordinated with what you're doing, then they have a problem, because it may not, they may, for instance, an INR might have a list of 10 different housing options, and you might have a different list, and it might not line up, and then the data won't be comparable.
Yes.
So I just was curious about whether you have any control or any influence on the intramural, or not intramural, but the NIH, the national institutes, in their common data element.
We do not, Jim, and I'm looking at this housing and food insecurity. I see housing is using FENX, which is a different survey instrument. And I haven't seen any folks who are representing or stewarding FENX to do any mapping through gravity. I looked at the RADX-up, which is the steward for food insecurity, but the RADX is mostly for, I believe, not just for food insecurity, but also for food and nutrition. I have not seen any representation or representatives from those organizations either in the Gravity project. But I would be happy to kind of get more, see if I can have any contact information for folks from those organizations, so I can kind of loop them into Gravity, so that we can close that loop, because NIH, like, as you know, Jim, is more of a research and clinical trials institute, and less of there's this strange disconnect between NIH and what's happening in the community health center field. OMOP maybe is trying to bridge that gap. Jim, we are working with Paul Nagy and with Hopkins to try to map OMOP elements onto different social determinants of health elements. But that's in process, and we need kind of more help. We're a 3-man team doing it, so it's been pretty tough. So I kind of invite everyone here, participants here, if you know people or you are interested in contributing and really helping our underserved communities and minority communities, please reach out to us, and we need as much help as we can. So questions? I see Santosh is here. And Jim, you're looking good, Jim. Last time I saw you was in San Diego. So there. So thanks again to Dr. Wang for setting this up, and more exciting Power Talks to come. This initiative is really great. So thank you very much again.
Yeah, thanks for giving this talk. I'm glad to see all these efforts that someone like that you're involved with this effort to. I mean, it's obvious that we haven't been capturing the social determinants of health, and now it's getting all this attention, and we don't know because we haven't been capturing it. So I'm glad to see that all this coordinated activity to get it collected and standardized.
Yeah.
Any final questions before we let everybody go? Final answer. All right. Well, if not, then everybody have a great weekend. Thanks for the speakers. Thanks for people who attended. And next week's talk is Wayne Liang. He was former faculty here and Hema and Informatics currently at Emory and in the Children's Hospital there in Atlanta. Development of computable pediatric chemotherapeutic regimen knowledge for cancer clinical care and research. All right, thanks everybody. Bye. Have a great weekend.
Thanks everyone. Thanks Jim. Thanks Dr. Wang. Thanks Amy. You guys are my heroes.